selection for intracytoplasmic sperm injection, called ICSI. At the conclusion of this presentation, participants should be able to describe factors to be considered in patient selection for use of ICSI, list the evidence-based indications for use of ICSI for male factor and non-male factor infertility. ICSI is an assisted reproductive technology that uses a needle to inject a single processed spermatozoan directly into the ovum. Since the first successful pregnancies using ICSI were published in 1992, a large number of babies have been born worldwide from this technology. The ICSI procedure has revolutionized how clinicians treat male factor infertility, as viable embryos can now be generated for patients with diminished semen parameters. The etiologies of male factor infertility can be broadly categorized into three main groups. Identifiable and reversible causes include ductal obstruction, hypogonadotropic hypogonadism, and varicocele. Identifiable and irreversible causes include testicular atrophy, such as with viral orchitis, or after iatrogenic insult, such as chemotherapy or radiation. In men with normal semen analysis, the cause of infertility cannot always be determined and is termed idiopathic. While the diagnostic criteria used to identify male factor infertility fail to predict with perfect accuracy poor or absent fertilization in ART, studies to date support the safety and efficacy of ICSI to treat various male factor conditions. We will discuss the indications for the use of ICSI for both male factor and non-male factor infertility. Abnormal sperm parameters are primary indications for ICSI. These abnormalities range from oligospermia to complete azoospermia. Specifically, these may include asthenozoospermia, teratozoospermia, and cryptozoospermia. Recall the World Health Organization's 2010 50th percentile and lower reference limit semen parameters as shown here. The lower reference limit represents the 5th percentile of men whose partner's time to spontaneous pregnancy was less than 12 months. For example, the 50th percentile for total sperm number within the ejaculate is 196 million per milliliter, while the lower reference limit for the general population is 39 million spermatozoa per milliliter. Any sperm parameters below the lower reference limits may suggest the issue of infertility, but do not necessarily correlate with IVF success. A complete absence of spermatozoa from the ejaculate occurs in 1% of all men and 10 to 15% of all infertile men. Diagnosis of azoospermia requires confirmation of absence by at least 2 semen analyses and is subcategorized into obstructive and non-obstructive azoospermia. Diagnosed azoospermia is a chief indication for ICSI. Until advanced micromanipulation techniques were pioneered, couples experiencing such conditions relied on limited solutions that included donor sperm or adoption. The obstructive form of azoospermia can result from congenital bilateral absence of the vas deferens, trauma, infection, vasectomy, or failed vasectomy reversal. Sperm retrieval and subsequent ICSI may be achieved via epididymal aspirations, including microscopic, MESA, percutaneous, PESA, and testicular fine needle aspiration. Since MESA typically allows retrieval of more sperm of higher quality, only one intervention is usually needed to provide adequate sperm for multiple attempts at ICSI. Repeat percutaneous testicular aspirations may become necessary if the first ART procedure does not result in a live birth. MESA requires microsurgical expertise and is typically performed in an operating room with either local, regional, or general anesthesia, thus making it more costly than other sperm retrieval techniques. In case series reporting the results of sperm retrieval and ICSI for men with obstructive azoospermia, pregnancy rates per retrieval attempt have been comparable or better than those achieved for similar couples at the same centers using ejaculated sperm. The more severe, non-obstructed form of azoospermia requires surgical intervention of the testicle to obtain spermatozoa for subsequent ICSI use. Testicular sperm extraction and microtesy retrieve seminiferous tubules, which are then searched for sperm under the microscope. Microtesy utilizes high magnification microdissection of dilated tubules and achieves a higher probability of sperm retrieval and maintains a greater anatomical integrity of the testicle. Sperm retrieved directly from the testis are generally limited in numbers and often exhibit no motility or non-progressive motility, but nevertheless typically still are viable and almost always functional for use in vitro fertilization and ICSI. Secretory azoospermia can be subcategorized as hypospermatogenesis, maturation arrest, Sertoli cell-only syndrome, or necrozoospermia, and is typically considered upon failed distal epididymal sperm retrieval. Testicular biopsies are utilized to treat such conditions in the form of TESI and, more recently, microtesy procedures. Specific chromosomal abnormalities can include aneuploidy, such as Klinefelter syndrome, which accounts for 2/3 of the genetic anomalies observed in the infertile male population. Infertility treatment of men with Klinefelter syndrome focuses on sperm retrieval. Successful surgical sperm retrieval through TESI has been reported in up to 69% of men with Klinefelter syndrome. This surgically retrieved sperm can be used for IVF-ICSI, and many live births of 46XY and 46XX children have been reported. Individual sperm from Klinefelter syndrome men were reported to have a slight increase in sex chromosomal and autosomal disomy. However, only one case of a 47XXY fetus that was terminated has been reported. All other children reported had normal karyotypes. Structural abnormalities of the autosomal chromosomes, such as inversions and translocations, have a higher frequency in the infertile male population than the general population and often need to be considered. Another indication for ICSI is sperm cell aneuploidy, which can be assessed by fluorescence in situ hybridization technology. Men with the highest risk of sperm aneuploidy are those with karyotypic abnormalities, severely abnormal sperm morphology, and non-obstructive azoospermia. Currently, limitations to the routine use of this technology include cost, inability to screen the actual sperm used in ICSI, and difficulty in assigning a meaningful risk assessment to couples based on the test results. As part of the ICSI procedure, the operator selects the most morphologically normal sperm, immobilizes it, and then gently injects it into the egg. Under the assumption that genetically abnormal spermatozoa have a dysmorphic appearance, the selection process may help those with a low number of normal forms due to chromosomal abnormalities. Even with aneuploidy screening and careful sperm selection, it is still possible that abnormal sperm may be picked up for ICSI. Acrosome defects are also indications for the use of ICSI. Globozoospermia is a rare and extreme acrosome defect in which all of the spermatozoa have round heads and lack an acrosome. It is associated with male infertility, as these sperm are unable to undergo the acrosome reaction necessary for binding to the oocyte and thus complete the process of fertilization. ICSI is a treatment option for these men. However, fertilization rates even after ICSI are low. Antisperm antibodies are a rare cause of male subfertility that do not require routine testing and can be treated with ICSI. Testing for ASA historically has been done when the semen analysis reveals isolated Azoospermia with normal sperm concentration or sperm agglutination or aggregation. ASAs can be found in the serum, in seminal plasma, or bound directly to sperm. ASAs can form when there is a breach in the blood-testis barrier and the immune system is exposed to large quantities of sperm antigens, such as with trauma, torsion, biopsy, orchitis, testicular cancer, or after vasectomy. Sperm-bound antibodies are thought to be clinically important because they can decrease motility, block penetration of the cervical mucus, and prevent sperm-egg binding, and thereby decrease the likelihood for fertilization and conception. Although some have suggested ASA testing for couples with unexplained infertility, the clinical utility of the test in such couples is uncertain, and ASA testing is unnecessary if ICSI is planned. Sperm viability testing is often utilized when there is evidence of Azoospermia, defined as complete lack of progressive motility. The staining of spermatozoa with eosin, or trypan blue, will identify cells with intact membranes, as live cells will appear white since the stain is not able to get into the cell through breaks in the membrane. The image shows sperm stained with 0.5% eosin Y. Viable sperm do not retain the stain, as shown in panel A, whereas non-viable sperm stain red at the head region, as shown in panel B. The hypoosmotic swelling test can also be used as a viability test. Placing sperm in a hypoosmotic buffer will result in swelling of live sperm due to the movement of fluid into the cell to maintain the osmotic balance. Dead sperm do not swell due to a non-functional membrane. The Haas test is often used as a means to identify viable sperm to choose for ICSI in a fraction of completely immotile sperm. Immotile yet viable spermatozoa can be used successfully with ICSI. The use of ICSI following prior total failed standard IVF fertilization with normal semen analysis in a prior IVF cycle is advocated to reduce the risk of subsequent failed fertilization. Retrospective studies have shown that in cycles where there was total fertilization failure in IVF with conventional insemination, subsequent fertilization rates using IVF and conventional insemination again ranged from 30 to 97%. Subsequent total failed fertilization was correlated with number of follicles, oocytes retrieved, and mature oocytes. Thus, there may also be a female component. In a prospective study, sister oocytes were allocated to conventional insemination versus ICSI in the IVF cycle following total failed fertilization with IVF conventional insemination. In this study, subsequent conventional insemination resulted in 12 of 109, 11%, oocytes fertilized by IVF conventional insemination, and 78 of 162, 48%, fertilized with IVF ICSI. Although subsequent total failed fertilization may be related to quality of the IVF stimulation, utilizing IVF ICSI may decrease the risk of subsequent poor fertilization failure and improve outcomes. ICSI can also play a role in fertility preservation. Oocyte cryopreservation involves the removal of the cumulus cells prior to freezing. Cryopreservation and thawing may lead to changes in the zona pellucida that could reduce fertilization rates with conventional insemination. For these reasons, ICSI has been the preferred method of fertilizing cryopreserved oocytes. Limited data exist comparing conventional insemination to ICSI for cryopreserved oocytes. ICSI is also indicated following semen cryopreservation for cancer patients due to the low motility and viability of sperm after thaw. Immature germ cell cryopreservation will require tissue transplant or in vitro maturation of the cells into mature sperm. Yields of mature sperm may be sufficient only for ICSI. This is currently in animal research trials. The ICSI procedure is also used for IVF cycles in which embryo biopsy and pre-implantation genetic diagnosis are planned. Insemination by ICSI avoids potential contamination of embryo biopsies with accessory sperm that would be present following standard IVF insemination. PGD is utilized to avoid transmission of serious recurrent disorders by identifying single gene mutations from biopsied blastomeres after polymerase chain reaction, whole genome amplification, or single nucleotide polymorphism arrays. Furthermore, the sex of the embryo, as well as chromosomal translocation, can be identified using FISH. Insemination by ICSI avoids the potential contamination of the embryo biopsies with accessory sperm that are often present on the zona pellucida following standard in vitro insemination, thereby limiting the chance of a potential false diagnosis. There have been questions about the role of routine testing for spermatozoan DNA fragmentation and whether testing is predictive of pregnancy with ICSI. Pregnancy rates have been shown to be independent of DNA fragmentation test results. Although a considerable proportion of processed semen samples used for ICSI have a high amount of fragmentation, the percent of fragmentation, genetic integrity, of the processed semen samples does not appear to be related to the ICSI outcome. Therefore, since DNA fragmentation is not associated with IVF ICSI success overall, there is insufficient evidence to recommend routine DNA fragmentation testing for patients undergoing IVF ICSI. Very few studies have examined the relationship between sperm DNA fragmentation and pregnancy loss. A recent meta-analysis found a significant association with pregnancy loss after IVF and ICSI. Other situations in which ICSI may be the preferential solution include post-thaw sperm samples that have poor survival and in vitro matured oocytes. Available evidence does not support the routine use of ICSI for non-male factor infertility. Based on current evidence, clinical outcomes are not improved for unexplained infertility, low oocyte yield, and advanced maternal age. ICSI may improve fertilization rates in a subsequent cycle following total failed fertilization in a prior IVF conventional insemination cycle, although fertilization failure seems to correlate with poor ovarian stimulation. ICSI for routine use may decrease the incidence of unexpected failed fertilization. However, more than 30 couples would have to undergo ICSI unnecessarily to prevent one failed fertilization. Selecting only one isolated spermatozoon for contact with an oocyte significantly decreases the chance of viral transmission of HIV, HBV, and HCV, among other infectious organisms. Viruses that are freely present in semen and bound to accompanying cells are removed or reduced in number when sperm are centrifuged through a density gradient, which further decreases the probability of transmission. In studies of male factor infertility, ICSI has been associated with a small increased risk of adverse outcomes in offspring. Specifically, reports indicate a slightly higher risk of transmitted chromosomal aberrations to the child. This may be caused by the use of genetically abnormal spermatozoa during ICSI. Since pregnancy could not be achieved through intercourse, the spermatozoa used for ICSI may possibly be dysfunctional and may carry abnormal genetic traits. In addition, infertile males show increased chromosomal anomalies such as sex chromosome aneuploidy, cystic fibrosis, males with congenital bilateral absence of the vas deferens, CBAVD, and YQ chromosome microdeletions. ICSI is a safe and effective therapy for the treatment of male factor infertility. Thanks to progressing technology and continued learning, men with extremely compromised sperm parameters have a chance to conceive children. However, there are no data to support the routine use of ICSI for non-male factor infertility. ICSI will remain an important treatment option as researchers are continuing to strive toward the ultimate goal of curing infertility. Thank you for participating in this educational activity.